patients seeking for infertility related treatments, has it gone up? Or
Yes, much higher.
Whenever there's an infertility problem, we look down upon the women as if that is the worst thing that happened to her.
Absolutely.
Has that changed, and are we open to considering male factors as well?
50%, that's 1 in 2 couples who do not have children, are directly, indirectly related to the man.
At what time that they should come to an infertility specialist?
If you are older than 35, then the 1 year wait may be a little too longer for you to seek help.
What is the best age for a woman to get pregnant?
Men make sperms throughout their lives.
Can we just quickly touch upon the guilt and shame of this kind of a patient context? I want to ask you, how about the vaping? Any research on that? The first thing that they are scared about IVF is, will this be my baby?
Absolutely. When they come to us, first thing, we don't really go out and tell them go for an IVF. So the man is a shy animal, honestly, and he would not go and consult a doctor itself. So he's the worst.
Doing multiple IVF cycles can permanently harm a woman's body.
Absolutely no myth. IVF does not cause any damage to any of the body organs. In fact, there are many countries which offer multiple IVFs for free for their residents. So IVF is safe, period.
Welcome to another episode of our podcast series, Gut Feeling with Dr. Pal. In this episode, we have interviewed Dr. Rohit Gudgutia from Nova IVF. We talked a lot about infertility treatments, all your questions about in terms of infertility, what is the cost involved, what are the reasons, whether it is a male cause or a female cause. We went in detail. I'm sure you'll enjoy it. Please share this podcast with a person who you think they're going through the same journey, so they don't have to go through the pain by themselves, so we can all help each other to have a better outcome. Let's dive deep into it. Hi, Dr. Rohit. Thank you so much for being my podcast.
Pleasure.
I'm very excited for the whole podcast and also on your name. Dr. Rohit Gudgutia. Yeah, I think that's why I have you in my podcast, Gut Feeling.
Yeah, I understand that. In fact, it's 2 guts.
2 guts.
So, I should have been there before.
And you had the guts to have the male gynecologist like 25 years ago. You're from Kolkata?
Yeah, I'm from Kolkata.
And we as an audience, my channel audience, we sometimes focus a lot more on PCOS, hormonal imbalances, most of the demographics of women, because I talk a lot about intermittent fasting and time restricted feeding.
Absolutely.
So when we reset our circadian rhythm, the hormones get back to normal sometimes. And women are getting affected a lot more because of the change in the circadian rhythm. And I always feel like the infertility rates or the PCOS problem may be connected to this hormonal imbalance as well. In your experience, how is this PCOS symptoms and incidence compared to before?
See, I've been practicing for 2 decades now. So what I can tell you is the idea of PCOS is now well established. Earlier, maybe there was some less diagnosis happening, so we really do not know about the incidence 2 decades back. But today in my practice, I'm sure that 3 out of 10 women who come to us for infertility would be having an underlying cause of PCOS. If you talk about around 2 decades back, that would have been maybe 1 out of 10. So there has been a 3 times increase in the PCOS incidence, is what I would say on a very conservative basis. I would say that this is kind of related to the diet, as you mentioned, sedentary lifestyle that we nowadays have, and also to the fact that maybe the pollution and everything put together, that's kind of affecting the hormonal rhythm, as you mentioned, and affecting their health. So,
and the patient seeking for infertility related treatments, has it gone up? Or is it the same?
No. Much higher. So, World Health Organization last to last year, they published a data which unfortunately did not include India as such, but overall the worldwide, they said 1 out of 7 couples are now suffering from infertility. That is, couples wanting to conceive but not able to conceive. And we have kind of related data from our country as well, Southeast Asia, and this is pretty much the same or maybe even higher. Unfortunately, as you understand Indian context, the reporting is not as robust as you would want it to be. So, and there's something called the secondary infertility, where you have a child and you're wanting a second child, but you're not getting pregnant. Most of these couples still haven't gotten around to consulting doctors, and therefore the data doesn't get captured. If we look at the whole picture, I would say it's something like 1 in 6 or 1 in 7 couples in our country as well, which is sad because India is a young country.
In country, yeah, 1 in 7.
1 in 7 couples.
Do we have any data which are in terms of, there is a separate category called male infertility?
Absolutely.
It is not only females.
Absolutely.
Previously, when I was doing medical school here, whenever there's an infertility problem, we look down upon the women as if that is the worst thing that happened to her.
Absolutely.
Has that changed, and are we open to considering male factors as well?
No, good that you talk about this. To be very honest, again, and I studied in medical colleges in the 90s, and we never had something called male infertility. So, and we were told that infertility is basically a women's problem, and that's how you should deal with it. In fact, even now in most medical colleges, the infertility section is part of OBGYN, so which is kind of a illusion that if women do not get pregnant, it must be something wrong with them. But honestly, and I'm telling you this is from my practice and also from colleagues that we talk all the time, 50%, that's 1 in 2 couples who do not have children, are directly, indirectly related to the man.
Wow.
The man could be like not having good quality sperm, could be sexual dysfunction, could be something else also. If we talk about the PCO in women, there must be a male equivalent which we are not aware of. Maybe diabetes, maybe obesity, maybe something else. So all put together, there is definitely this understanding that the man is equally, if not lesser, responsible for the infertility demon that's now affecting our country.
When a person listening to this podcast, so let's say they want to know more about the infertility treatment options, at what time that they should come to an infertility specialist?
Okay, so see, first of all, infertility is never an individual diagnosis. You have to exist as a couple, try for a baby for at least a year, and we call this regular, unprotected, penetrative ejaculatory intercourse to define it on a regular basis, which is basically twice a week at least. And if you haven't succeeded to conceive in years' time, that's when you can consider that you're suffering from infertility, and that's when you see a doctor. If you are older than 35, then the 1 year wait may be a little too longer for you to seek help. So for you, maybe 6 months is a good time for you to seek help. But otherwise, it's a year's time of trying, and if no pregnancy, then go and see a doctor.
And I'm going to ask you a controversial question.
Absolutely.
And if you're not comfortable, please feel free to ignore. What is the best age for a woman to get pregnant?
Okay, so the politically right answer is when she feels like it. So of course, as we keep saying in our social discussions and academic conferences also, women have evolved, and we cannot shy away from this fact. They have an equal right to studying, to a career, to financial independence, and you cannot take that away. They're just not only meant to bear children. So much so that even today, we first need to recognize that her primary right is to exist as an individual and not as a mother. Having said that, we also need to look at the human physiology. Men make sperms throughout their lives. So technically speaking, they're capable of fathering children even into their 60s and 70s. It's another situation where as you grow older, the sperm quality worsens, and that's a different topic. But unfortunately for women, they're born with a fixed number of eggs, and that cannot change. And almost on a daily basis, they're exhausting their eggs. We put a number of something like 30 odd eggs are going waste on a daily basis. So she's using up almost 1,000 eggs a month. And she was born with a fixed number of eggs. By our estimates, she has around 400,000 eggs by the time she started her menses.
I see.
So that translates to maybe 400 menstrual cycles. Now, by the time she's 30, she's used up 3/5 of those eggs. Now, if she doesn't get around getting pregnant, then maybe by the time she's willing to become a mother, she would have used up most of her good eggs. And that's a warning that we are kind of bringing out in the fore with people like you through your podcasts, that people should understand that this is what the female biological clock is all about. This is not to be confused with their independence to become parents or mothers as they may want to. One way of handling this could be if they could go around and freeze their oocytes at the right time. But that we also understand is a socially evolving concept, and we cannot really impose this on a general population just right now.
I was about to ask you that, when I was studying gynecology, women more than 35 years of age, they are at slightly increased risk of chromosomal abnormalities with the baby because of the advancing maternal age is directly proportional to the possible chromosomal abnormalities. And that's why they say that, it doesn't mean that if you are more than 35, you will not have a normal baby. The risk is slightly higher. So now, always the question is, should I have to wait for the right partner? Or get married just because my age is running out? In that situation, this freezing of the oocytes, the ovum, is a possible option. Absolutely. That's what you're talking about.
Absolutely.
Yeah. And how effective is this? If they freeze the ovum, they can use it anytime later?
It's a very common question, and we get asked very often also. See, the point is, the first and the best option is get pregnant naturally. And there's no way that we are trying to advocate that this is an alternate to natural conception. But in case you are looking for the right partner and you think your biological clock is ticking, then the second best option would be to go and get your eggs frozen. Now, once you've frozen your eggs, we've kind of given you reproductive insurance, in the sense that you can now start your pregnancy planning on a more colder, planned way. You have eggs frozen, and law allows us to freeze them for almost 10 years now. So you have that window in which you can plan your life. The happy point is that even if people have frozen their eggs, only about 20% of these women have come back to use those eggs. So in most circumstances, freezing doesn't mean they'll have to come back and use them. Again, with frozen eggs also, most of these women would actually conceive naturally when they wanted to. It's just the plan B is there, and you're much more relaxed in your search for a right partner, that you know your eggs are frozen. With a frozen egg cycle, of course, you're not looking at 100% conception. You would be looking at a 30 to 50% chance of conception, depending on what age you freeze your eggs, how many eggs were frozen, etc. But this is an idea, a concept that should be understood by women while they are planning their parenthood. So this is something that's a food for thought.
So it's an option.
It's an option.
It's an option. So a person listening to this podcast, let's say they're 25 years old or 28. They have not found the right partner and they want to settle down in career, find the right partner. So you would say, like, before 30, you could consider this as an option.
So I'll just interrupt, and I'll bring a new concept here. That is the checking of your ovarian reserve. So it's a simple blood test, non-invasive. You do it any time of the month. There's no issue about being on empty stomach or something. And that's called a AMH, or anti-Mullerian hormone. So if you check your blood levels, it gives you a good indicator about your ovarian reserve. Now, if you are lucky to have a good ovarian reserve and you are 28, you could hold on to your egg freezing plans for a couple of years more and go out and freeze eggs 2 years later as well. But in case your AMH levels are slightly lower, and you are also not very sure when you're going to get married and you plan a pregnancy, then it's a good idea to consult a fertility doctor, freeze your eggs, and be ready for the next step as it comes. So you have this kind of flexibility, personalization, that's available. A blood test to check your ovarian status is a very simple thing to do.
Nice. That's an option.
That's an option as well. Yeah.
Wonderful. So, you work at Nova IVF, and you guys have 120 centers. That's mind-blowing. But in these 120 centers, is this technique is getting more common in the last couple of years, or there is hesitancy?
Yes, of course, I represent Nova IVF, and I'm incredibly proud of the work that we do. We've grown from something like 6-7 centers in 2012 to 120 now. And in all of our centers, egg freezing or social egg freezing is actively promoted, because we feel that this is one way of ensuring independence for the woman. Having said that, I'll also need to mention here that egg freezing is one aspect where the incidence of freezing of eggs has grown by leaps and bounds. So I would say that COVID had something to do with it. Post-COVID, incidence of egg freezing in all our clinics has jumped by 4 times. And we see this increasing year on year. As more and more women come and freeze eggs, they kind of talk in their peer group. And then more of their friends get interested. And I see this is a trend that's going to go up. Even if you refer to the Western world, this amount of egg freezing, this is something that's growing up on an annual basis more than 20-25%. So we see that this aspect of fertility preservation is going to grow for the next few years.
So we talked about women freezing their ovum. we also know that as age advances, the sperm quality declines as well. Will that be applied to the men as well for preserving the semen?
I'm so happy you asked a man question. See, the point is, yes, as you said, men also have a gradual decline in sperm quality, but somehow sperm freezing has not caught on to that extent. But yes, there is another segment that I need to talk to you about, and that is the segment of oncofertility. So in oncofertility, basically we're going out and freezing, not by choice, but mostly by compulsion, both the eggs for the female partner and also the sperms for the man, in case they're suffering or been diagnosed with cancer, and they're awaiting either a surgery or a chemo or a radiotherapy, post which there's a very high chance that the gametes may be damaged or they may not be available for future pregnancies. So this is one aspect I really need to bring out through your fora, is that if there is a possibility that a person has been diagnosed with cancer and would plan a pregnancy post the treatment, then they should go and freeze their eggs and sperms. And that's also something that's developing, catching on. Our onco friends, the people who do oncosurgeries, oncotherapies, they are also aggressively advocating this for patients.
So, we talked about infertility. The number one reason that everybody is talking about is, obesity, metabolic syndrome, pro-inflammation. What is the most common cause in men?
Okay, so men, we are not very sure, but there seems to be a data that the sperm quality is consistently declining. And we would again put it down to sedentary lifestyle and obesity as a first go. But I like to bring in here something called the endocrine disruptors. So the pollution, the exposure to microplastics, maybe that has something to do with the quality of the sperm that's declining so fast. And I'd like to tell you, this is not only in humans. This is also happening in the marine population, also in animal world. We are realizing that the exposure, the air quality is having an effect on the sperm quality all across. So let this be a warning signal that unless we mend our ways, maybe the man will not be able to get his wife pregnant or his partner pregnant unless the sperm quality improves.
Just as a thought, since you said about air pollution, in India, the air quality index in the northern part of India, especially Delhi,
absolutely.
is around 400, 500 crazy high.
Absolutely.
Is that related to increasing infertility rates?
I would assume, because then you have more male infertility in the urban population. So that's a kind of a direct message that pollution has to do something with the sperm quality.
So let's say a couple tried for a year and either it's a PCOS related or maybe smoking is one of the most important causes of male infertility.
Yeah, but luckily it's coming down.
It's coming down.
Yeah, so you see less and less smokers now.
I want to ask you, how about the vaping? Any research on that?
Yeah, so whatever we've learned now so far is vaping is worse.
Vaping is worse than smoking for
so we thought that maybe a nicotine gum or vaping would be better, but what we are understanding from vaping, and vaping is something that's caught on badly, both with men and women.
Yes.
So we thought that it's safer, maybe it's more fashionable, but it seems the early research is saying that vaping is in fact worse than smoking.
Okay, perfect. Wow, I'm learning a lot of information. Thank you. That's why I love doing this podcast. I can learn from so many specialities. So let's say a couple is trying for a year, as you said, unprotected penetrative ejaculative intercourse 2 times a week, didn't work out, coming to you. The first thing that they are scared about IVF is, will this be my baby?
Absolutely. When they've come to us, first thing, we don't really go out and tell them go for an IVF. So we try and find out what will be the reason why they're not getting pregnant. And if you take the reference to the 2020 cricket matches, it's only about 20% couples who come to us who end up with an IVF.
Is that right?
Yeah. So most cases...
4 in 5
yeah, absolutely.
Get pregnant.
4 out of 5
would
get pregnant without IVF. So mostly they need subtle correction of PCOS, as we said. PCO, luckily, is a common problem, but it's a problem that's amenable to treatment. So most people with PCO have what is known as anovulatory infertility. That is, their eggs are not growing up. They're present, but they're not responding. So once you give them medication, they would ovulate and they'll get pregnant. So also for most men, some simple therapies would work for them. It's only about 1 in 5 that would require an IVF. But once we decide for an IVF, we need to tell them that this is the best option for them to go ahead and try and have their own child. Now, the concept of having their own child is very, very important for us at Nova. We feel that IVF in itself means making your own baby. So we call this the self cycle. The reason why we talk about self-cycle is most couples, initially at least, let's say 10, 12 years back when they came to us, they'd been kind of fed on stories that IVF center would do anything to get you pregnant, and they really don't care whether it's your own child or not. So this is something that has been ingrained. It's part of the DNA of the whole Nova system, that we first and foremost put your own gametes to the top. So that's what the self-cycle is all about.
Can you explain a little bit more about the self-cycle?
Okay, so what is an IVF? In IVF, basically the parents are not, the to-be or the would-be parents are not getting pregnant, and in most cases either there is a mechanical issue or there's a quality issue. So what we do is we stimulate the female partner with hormones, make her eggs grow up, extract those eggs, fertilize with the partner's sperms, make embryos and put it back in the womb. Now it's a given that the same person's eggs and the same person's sperms or partner's sperms would be used to make babies. And that's how you would have your own baby. Now, why do we want children in the first place? Maybe that's our shot at immortality. We want to see our reflection in our kids, our smile, our eyes, our nose, the way we sleep, the way we walk, the way we talk. This is what we want to look in our children. Basically, our traits and our genes. Now, what happens is that this simple understanding is not always there in the clients or the patient's minds. They tend to feel that getting pregnant any which way is the goal of an IVF. So that's the distinction that we want to achieve in our practice always, is that no, we're talking about your own eggs, your own sperms, and therefore a self-IVF. It's not that we need to talk about in such details, but the unfortunate reality is that the whole IVF story in our country has been caught up in success rates. As in, these many people went for an IVF, these people got pregnant. Now, success has to be also looked at with satisfaction. And the satisfaction index is best or highest when you're getting pregnant with your own gametes. And this is what the self-cycle is all about.
But it is your own gamete.
In most circumstances, it is your own gametes. Rarely, when the egg quality is not so good, or maybe the female partner is past the age of producing eggs, or in extremely rare circumstances where the sperms are not there at all, or the sperm quality is extremely bad, or if there is a genetic condition which does not allow for the birth of a healthy baby, that's when we talk about what is known as a donor gamete IVF cycle. But that's, let's say in Nova's practice, 80% of the cycles that we do in our practice is self-cycle. And only about 20% cycles we end up doing a donor cycle. This is something that is fundamental and simple to understand, but very often lost when we try and explain this to our clients, to our patients, because they have been fed on stories that maybe IVF is all about getting a child and not necessarily your own child.
So we are breaking the myth that majority of the IVF is your own embryo, own ovum,
Absolutely,
own sperm,
absolutely,
and
absolutely.
then your own embryo.
In an IVF practice, the goal is always your own child, and that is something that's not a myth. Basically, that's the reality. That's how it should be. A child born to you essentially should be your own eggs and your own sperms. The self cycle.
And let's say there is a medical condition precluding to have that. Sperm and also ovum can be chosen.
Yeah, so in some circumstances it's the egg that's replaced, in some other circumstances the sperm, and in an extremely rare situation both the sperm and the egg may need to be replaced, and that's known as an embryo donation. So that's how the donation cycle pans out.
Embryo donation. Things have advanced, and I also know that for genetic abnormalities, people do IVF. And then they will biopsy the embryo to see, right?
Wow. So
can you explain that?
That's technically now possible. So when we create embryos out of eggs and sperms, we grow them in the labs and we observe them. After they've reached a particular size, that's called a blastocyst, we can actually take out cells from the blastocyst, take out the DNA from that cells, analyze that DNA and look for defects. So it could be a karyotyping defect or a chromosomal defect. It could also be a genetic defect, and both of these can be checked. And in case we want to be sure that the baby is born healthy, like there's no Down syndrome, so we can actually check for that and give birth to a healthy child. If there is a genetic condition in the family, such as thalassemia is very common in our country, so if both the parents are carriers for thalassemia and they don't want a baby to suffer from thalassemia, you can actually create embryos, check them for thalassemia, and then transfer a healthy embryo back. So this is known as PGT. PGT stands for pre-implantation genetic testing of embryos. So you can check the embryos and then transfer the healthy embryos. There are two advantages. You do not replace an unhealthy embryo, so there's no risk of checking the embryos post-pregnancy or undergoing unfortunate miscarriages after you've gotten pregnant. The second advantage is, of course, you reduce the social burden that a baby who's suffering from a disease is born. The whole country, the whole society suffers because of that. So you reduce that.
Wow. This is mind-blowing. The PGT that you talked about, pre-genetic testing, in your practice, I'm just asking out of curiosity, do you think that should happen before marriage?
Oh, so beautifully you've asked this question. Absolutely. So the government also, like say in Bengal, where thalassemia is pretty common, the government does require that you check for thalassemia status before you get married. I would suggest that in some advanced countries across the world, it has now become mandatory to check for your genetic conditions before you get married. But a country as large population such as India is not going to be feasible to ask for a genetic testing for all couples before they get married.
Right.
But in case you are aware that there's a genetic condition in their family, it's always sensible to check yourself as well, and then look for a partner whose family doesn't carry the same disease. So that's the best thing that you can do before you actually plan a pregnancy.
I would say that in addition to the astrology, this needs to be done.
Absolutely, absolutely. So this is the modern day astrology.
Correct.
So this is where you need to do.
In addition to asking how much do you earn?
Absolutely. Yeah.
See, I have worked with IVF centers, and let's just touch a little bit about the role of lifestyle and IVF successful outcomes. So, we do have a weight loss program. It's called New Me, which is in California, and now it's virtually available. So, a lot of PCOS patients come to us, and what we have seen is if we are not priming the gut health, and if the patients are getting started on, you name it, clomiphene or any other IUI or any other artificial procedures, ART, artificial reproductive techniques.
I'll correct you here. So this is one myth that we need to bust. That is, most people refer to ART as artificial reproductive techniques. We are not doing anything artificial. It is assisted reproductive techniques.
Oh, I see.
So we are assisting nature. We are not replacing nature.
I see. Assisted reproductive techniques, yeah. So what we have realized is if we fix the gut lining, this outcome of IVF is excellent.
Absolutely.
Is excellent. In your practice, do you think the lifestyle change plays a role? If so, if yes, how much?
So this is something that we need to learn from you, honestly. So when women come to us or when couples come to us, they're basically at the end of their tether. They do not have the patience to wait. So even though we would like them to correct themselves before they actively start their treatments, we do not have that kind of time or occasion to do that. But over time, we are realizing that gut is intimately related with reproductive health. And we are also being taught about things like microbiomes all the day, every time. Now, as I said, what we would like to do for most of our couples is to put them on a lifestyle program, try and make them optimize their BMIs, and then possibly start the active treatment. Doesn't always work out. So for us, things go hand in hand. But if there was some way where we could actively do this before we start treatment, I'm sure the results would be far better. I'll tell you about the story. So in PCOS with obesity, there was a research carried out in Italy that's around 10-12 years back when they put them on weight loss therapy, and almost 70% of those women who had just simple weight loss conceived naturally. So that's the power of weight loss. And by weight loss, we don't need them to lose too much of weight. Even 5 to 7% weight loss reduces anovulation, makes the cycles more regular, and therefore the chances of spontaneous conception increases.
Wow. So let's say 80 kilo women, 7 to 8% is only 5 or 6 kilos.
Absolutely.
But that makes a huge difference.
Huge difference.
We have seen that. Significantly we've seen that. And I'm involved in microbiome research in the US, and
we are creating all this axis, gut-brain axis, gut-skin axis. But what is the axis that everybody should understand is the HPA axis.
Absolutely.
And there's a strong connection in terms of the gut health, and there is certain bacteria that is much more prevalent in the dysfunction, and if there's a certain group of bacteria, it will be beneficial. We don't know yet which bacteria particularly that is responsible, that we can put that in the capsule and then take it as a probiotic.
Absolutely.
We are not there yet, but eventually 5 years from now, I think that's going to be like a game changer. So in your practice, you are saying it will go hand in hand, correct?
Absolutely.
Lifestyle plus ART techniques. So in your center,
But certain things like smoking, alcohol abuse, all that has to stop before we start treatment.
you will not start treatment if somebody continues to smoke. There's no point.
Ideally, yes. Ideally,
There's
we
no
would not
point.
start. Absolutely.
There's no point. And can we just quickly touch upon the guilt and shame of this kind of a patient context? Is it coming on the women's side, husband's side, or is the situation changing?
Again, let me speak for the man first. So the man is a shy animal, honestly, and he would not go and consult a doctor itself. So he's the worst. He feels shy to even face the doctor. And which is why, unfortunately, andrology, that is the male aspect of infertility, has not developed that well. Because men are not good patients. They'll simply avoid. And there's something called ICSI, that is intracytoplasmic sperm injection, where even if you have one or two functioning sperms, we can achieve a pregnancy by using that sperm to fertilize an egg. So ever since ICSI was discovered or invented 30 odd years back.
Can you educate the audience a little bit about ICSI?
So what happens in an ICSI is, so in a general semen sample, you would require something like 30-40 million sperms, and let's say half of which are motile, healthy looking sperms. But in case the sperm count is much lower than this, even then an ICSI can give you a pregnancy where we take one or two healthy sperms. One sperm is then injected into one egg, which has been retrieved from the female ovaries through the process of IVF or womb pickup. And that one sperm being injected to one egg will form an embryo, and there's a high chance that that embryo will then give us a pregnancy. So men with worst of semen samples can also father a child through an IVF process or assisted reproductive techniques. So once IVF has become the mainstay for treatment for men, unfortunately them seeking help for treatment for improvement of their sperm quality has gone down even further. Because we all know the solution for that is basically go for an IVF or an ICSI, and this will work out good for you. But there's no denying that lifestyle management is the best option if we could ever implement this for men. For women, yes, they are always suffering from guilt or shame, and that's mostly brought on to them by the family and the friends. So somehow we have this culture in our country where the women are looked at or upon as being responsible for bearing children. And we have this magic number: you're married for 2 years and you don't have a child, so you'll have unsolicited opinion, advice coming from everyone. And that's the biggest pain point. In fact, when people undergo IVF with us, they keep saying the same thing. Doesn't really matter if the cycle fails, but I don't know what I will answer to my mother-in-law, sister, whoever it is in their family who is the decision maker. So this is something that needs to be understood. Reproductive rights or choices are a person's individual preferences, and we need to respect that. We need to respect that. Women do seek help nowadays, and I see this as urban India. They're actually very open about coming and discussing about their problems. But half of the conversation that we do with them is also to do with the fact that they are suffering from guilt or shame at not being able to give a child or give an heir to the family as being pointed out by their family members. This is something that is going to change, is changing, and I'm sure will change.
And how important is a psychological support in this whole process?
Okay, yeah. So, see, at Nova, we understood this long back, that it's a journey. And when it's a journey, they need somebody to kind of partner them during that journey. It's not a quick fix solution. You don't have a 5 days antibiotic program, you take that and you get pregnant. And in some cases, you would start with the natural method of getting pregnant. If it doesn't work, then you move on to an IVF. In some other cases, you would start with an IVF. Maybe the first cycle doesn't work and you have to go for the second cycle. Most couples would require to be patient in their journey. And in any journey, you would have highs and lows. So you need somebody to hold hands with you. We have counselors who have our qualified psychologists basically, who have training to do this, who've understood the whole aspect of fertility, the pluses and the minuses of fertility treatment, and they're always there to hold hands with both the male and the female partner. Essentially, what they do is connect with them on a regular basis, keep them apprised of what's going to happen next, and also tell them the outcomes of the cycle, the treatments that have happened, empathetic to them. I would not say sympathetic, empathetic to them.
Yeah.
So that's what they need. And obviously judgment-free listening. So they just listen to the clients, understand their concerns, and they relay them to us. I would say our journey is made much more comfortable with the help of these counselors. And this is a unique feature that we have in Nova IVF.
So, many patients are obviously, understandably, they're stressed out of the whole process.
Absolutely.
And as far as we know, stress increases the cortisol levels. The sympathetic stimulation, how does it affect the outcome?
See, of course, the whole fertility journey or treatment for fertility is highly stressful. I wouldn't say that you can avoid stress. You need to manage stress. There is the financial angle. People have, and these are young couples.
Yeah.
So in most circumstances, it's self-funded. Unfortunately, in our country, there's no company funding or insurance funding that you have for these treatments. So you have to fund for the treatment. And then there's the stress of the success happening or not happening. And then there's a third stress of managing your job, your work responsibilities with the treatment. So, and there are inter-couple stress events also. So it's my problem versus your problem and how to handle these problems. So we realize that there's a stress. We also understand that stress needs to be managed. But to really say that stress affects the outcomes is, I would say it's stretching things. Because as such, stress does not lead to any direct impact on outcomes. It does make them take wrong decisions, hasty decisions. It clouds their vision. It makes them very panicky. They need to be handled with care, if I would say so. We need to be always present for their concerns. But by and large, stress is something that has to be managed. And here also I'll bring in the counselors. They do such a wonderful job. They're always there. They're the listening ears. They listen to them. They talk to them. And whenever somebody is feeling stressed out, they have special sessions for them. What we've also tried to do in Nova, and I'm sure that others are also doing it, is to bring certain couples together, people on a similar journey, and try and put them together with somebody who's gotten pregnant and given birth maybe. So maybe they learn from that person, talk to her. When there is a peer group going, people open up a lot more. They discuss their individual issues a lot better and more clearly. And that is also one way of stress management. Eventually, I would say this is a learning process for each and every couple. And over time, then learn to manage their own stress in their own way.
That's wonderfully put. And I cannot even imagine what people are going through. And especially after like 1 or 2 failed IVF cycles, the stress management is really important.
Absolutely.
That brings the next question in terms of the cost. So in the US, even in the US, it is not being covered by insurance.
Yes,
most of the times. And it is quite expensive. And even when I have worked in IVF centers, and they start by saying that the success outcome is only 50%. Or even, what would you say the successful outcome would be? 70%?
Yes. So on an average, again, because the technology is improving on a daily basis, the methods of identifying a healthy embryo has improved a lot. We have now artificial intelligence that's come in. With the help of AI, you can identify a good embryo, a healthy embryo far better.
Is that right? Tell me more about it. How does AI identify?
So basically, what we do is we grow the embryos in the lab. And when we grow the embryos in the lab, the only way of judging whether the embryo is healthy or not is looking at how fast or how evenly the embryo is growing.
Correct.
So we have predefined criteria so that the embryo should be fertilized on the next day of pickup. It should be 8 cells on day 3, and it should be 120 cells plus a blastocyst on day 5. We also look at the symmetry of the cells inside the embryo, the distribution of the cells, and that's how we call it a good-looking embryo versus a not-so-good-looking embryo. We grade these embryos. And this is the subjective method of judging the embryos in a non-invasive sort of a way. Now, the human eye can do this much, not more than that. Now you have better optics and you bring in AI. So what AI does, it has a list of, let's say, 10,000 embryos which went on to give birth. And it's run its own machine learning, and it knows that these are the features that it has to look for in a healthy embryo. So now you expose these embryos to the AI optics, and then the software takes over, and they tell us that this embryo has a 75% chance of implanting versus a 95% chance of implanting. And in most cases, because our embryologists are very experienced, there is a concurrence. That is, we also felt that this embryo is good, and the AI also says that this is good. So it's kind of a double validation that's happening, and then the AI also tells us this embryo is good, and that's how we try and select a good embryo. So this is how the whole process of selecting of embryo is happening. So because of this, the pregnancy rates through an IVF are consistently improving. There are other factors also, but this is largely the improvement in the lab culture conditions and the isolation of embryos, identification of embryos through AI. That's how the improvement has actually happened.
So with the improvement in techniques, the success rate is increasing. Do you think it will keep on increasing every year?
So when I started out 20 years back, we were like very happy if 20% of our couples got pregnant with the first attempt of IVF. Now we are not happy even if we have 55% pregnancy rates per attempt. So this is what has happened over the last 20 odd years. And I see the success rates improving for the next few years at least. The biggest reason I would say this has happened is because the lab conditions have become very standardized. You have far better air quality conditions because you have what is known as an air handling unit which keeps filtering the air all the time. You have far more robust incubators where the embryos are grown. You have far more trained and experienced embryologists who can select the embryos. And on the top of it, you have AI. Artificial intelligence. So what AI does is basically it looks at the embryo through its own optics and its own software, and it then tells us that this is a transferable embryo, meaning this embryo has a higher chance of giving us a birth. So all this put together is how IVF successes are improving almost on a yearly basis.
Wow. Looks like it's a multidisciplinary team.
Absolutely.
Correct? It's not only the gynecologist. So tell me in Nova IVF, who are all the team members involved?
Okay, so in any IVF practice, we are only the front face. So the gynac in an IVF unit is not the most important person. The heart and the soul of an IVF team is what is an embryologist. So the embryologist is the one who makes the embryos. He or she is the one who will put the egg and the sperm together, sometimes through the process of IVF, where we put the egg and the sperm together and hope for a fertilization the next day, or sometimes by injecting the sperm into the egg through the process of ICSI as we define, and create an embryo and check for the embryo's growth. And these embryologists are always working as team. And to make sure that the embryos are being cultured properly and correctly, we have what is known as double witnessing. Meaning if there's somebody who's working, there's somebody else who's watching, so that we make sure that there's nothing going wrong. In most cases, we also have what is known as electronic witnessing. So you have these machines which are put in the place of activity. So in case by chance there is some other gamete that is brought in vicinity of the eggs and the sperms of a particular person, the alarm goes off. And that's how you identify that you're not working with the right sperms and eggs. All this is in place to ensure the sanctity of the gametes, which is like very, very important for us at Nova.
Of course.
So this is how we keep promoting or be talking about the self cycle, meaning we want to be sure that we're using your own eggs and sperms to make your baby. So this is the science behind it, the whole process of making sure that we are culturing your embryos properly and growing them properly. Then of course you have other techs. You have a machine by which you can observe the embryos without taking the embryos out of the machine, and that's known as a time-lapse incubator. You also have the process of PGT, as we discussed. You also do many other tinkering things, like you do a laser hatching of the embryos to make sure that it implants better. All put together, these are techniques to improve your IVF successes.
Wow. And how do people...
And these are all carried out by the embryologists.
By embryologists.
Yeah. You of course have other people like androtechnicians who would work on the sperms, counselors, we discuss about counselors, the nursing staff.
And we briefly touched upon the cost. So what is the cost in India as of now?
There's no uniform cost as such, because it all depends on the type of patients we're dealing with. You could start as low as something like 1.5 lakh rupees to go as high as something like 3 lakh rupees, depending on what kind of treatment is being offered to you. Sometimes the cost is actually basically due to the injections that are administered to make the eggs grow up. So in most circumstances, they're uniform, but in some cases you require extra injections or some other quality of injections, so that's where the cost goes up. We really need to understand that most of this cost may sound a little on the higher side. That's because there's no kind of finance available. It's all self-funding. Now, of course, we have companies who are offering finance at zero interest, but by and large, it's all self-funding.
Self-funded, yeah. This is much cheaper than what is happening in the US.
Absolutely. They're 10-12 times higher.
10-12 times higher. And their next available appointment is 3-4 months from now.
Absolutely.
It's insane. So other problem I see in the Indian medical practice in general is patient privacy. I was in an elevator in one of the hospital over here, and they are talking about the patient using names and everything, and the patient is in the elevator.
True.
So how do we protect patient privacy in general, any IVF practice?
Okay, so the whole IVF practice hinges on privacy, because as we understand, there is some amount, I wouldn't say stigma, but there is some amount of a social hesitancy associated with the whole process of IVF. Now, having said that, we also need to understand that there is a government mandated law that we cannot leak out patient privacy details at all. So all our employees who work with us have to sign a contract that they will not discuss or reveal any kind of a patient identity ever again. And the whole environment in the clinic is such that we are all acutely aware that the patient's privacy has to be maintained or kept sacrosanct at all times. Most cases, the couples are referred by numbers, and the names are kept as often as possible under wraps.
Super. So I have a rapid fire segment for you.
Exciting.
Okay, all right. So the answer should be yes, no, or a little bit of an explanation.
Okay.
Number one, IVF babies are more likely to be sick or have health problems.
No.
Eating too much spicy food can make you infertile.
No.
IVF is only for rich people or celebrities.
No.
Caffeine stops you from conceiving.
Excessive caffeine may affect your fertility, but moderate amount, no.
Eating eggs daily will guarantee conception.
Will not guarantee conception, but will help in conception. Egg has protein, it has choline, and it has certain other vitamins as well.
Super. Doing multiple IVF cycles can permanently harm a woman's body.
Absolutely no. Myth. IVF does not cause any damage to any of the body organs. In fact, there are many countries which offer multiple IVFs for free for their residents. So IVF is safe, period.
Any limit to a cycle? Doesn't matter.
No, doesn't really matter. The most responsible doctors will ask you to stop after a particular number of cycles if it's not working out, or suggest an alternate, but there's no physical harm to you at all.
Super. Drinking alcohol once in a while, like social drinking, will not affect fertility.
Difficult question. You're supposed to say yes, but the answer is moderate drinking doesn't matter, but of course abuse is something that's a strict no-no.
If IVF doesn't work the first cycle, it will never work again.
No, it's meant to work in the first 3 or 4 cycles mostly. There is an equal chance of pregnancy happening whether it's a first or a second cycle. please do not give up if your first cycle doesn't work.
Super. Detox, diet and drink will boost IVF success.
Yes, I would say yes.
Stress will affect the IVF outcome.
Stress doesn't affect the IVF outcome, but in case you fail and you're stressed, it takes far longer for you to come back for the second cycle. It's our job to make sure that you're stress-free during your IVF cycle.
Super. Thank you so much. It was a wonderful,
Pleasure.
wonderful discussion. I learned a lot. Being a gastroenterologist, it is wonderful to hear input from other experts. One last piece of advice to people who's listening to this podcast so they can share to some other person who's in the same boat about IVF, infertility, anything that you can say has.
See, in today's age, what I understand is there are so many of you seeking help for fertility management. Don't feel shy about it. It's just like any other disease or any other condition. Just as you wouldn't mind seeing an eye person for your specs, just go and consult an infertility doctor for your IVF or for your ART treatment purposes. And please do also understand that 95% couples end up with their own kids, their self-cycle kids, if they have taken 3 or 4 attempts. So this is my message to all of you.
Super. Thank you so much for your time, sir.
Thank you.
Thank you.